Thanks to Dr. Veith. This is really, I guess, reiterating a little bit of the stuff that Lawrence and Marianne have just shown you. A lot of you familiar with Shockwave consists of a generator, a connector cable, and the catheter itself. And as Lawrence showed you, the emitters produce gas bubbles within the fluid-filled balloon. These gas bubbles expand and collapse, producing sonic pressure waves that microfragment the calcium, not only in the intima, but also in the media over a longitudinal length of the balloon. As Lawrence mentioned, this has been studied in 3 completed trials, 2 above-knee trials and 1 small below-knee trial. And just to reiterate, the Disrupt PAD-2 trial that presented 12-month results showed excellent acute gain in terms of luminal gain and excellent safety acutely. But there was significant restenosis by 12 months, although the restenosis was reduced if you used an optimal technique, that being adequate balloon oversizing, 1.1 to 1, and making sure there was adequate overlap of balloons and longer lesions. Well, really, the problem with this restenosis is being addressed in the Disrupt PAD-3 randomized controlled trial. So in this trial, as you can see, which is currently recruiting, patients are randomized to intravascular lithotripsy plus a drug-coated balloon compared to plain balloon angioplasty plus a drug-coated balloon. A very important trial. It was held up for a period of time while the paclitaxel issue was being discussed, but is currently back in recruitment and is close to closing recruitment. On the other side and alongside this has been an observational registry, which is not only patients who have failed inclusion in the trial, but all comers who have calcified disease in other peripheral arteries, iliac, common femoral, femoropopliteal, and below the knee. And the observational registry is actually extended to 1,500 patients, and this is recruited very quickly, over 1,000 patients currently recruited. What I'm going to show you is some data from the first 200 patients analysed using predominantly the femoropopliteal device available from 3 to 7 millimetres in diameter, but also the tibial S4 device from 2 to 3.5 millimetres in diameter. Here's a typical kind of case, heavily calcified femoral artery treated with intravascular lithotripsy and drug-coated balloon only, no stents. Similarly in the popliteal artery, and also the S4 catheter here in a calcified tibioperineal trunk. So as we have a look at these lesions, we can see compared to the randomized controlled trial, the lesions treated in the observational registry, there were many more geographies, the common femoral artery, the iliac artery, quite a small number of below the knees at this stage, although many more have been included. And you can see these are a much more hostile group of patients in terms of longer length, more CTOs, and more extensive calcification. But despite that, we've seen the same acute gain and the same very low incidence of significant adverse events. So a very good safety profile with an excellent luminal gain, despite this being a much more hostile group. And you can see this kind of luminal gain has been achieved in all the locations and all the lesion morphologies, longer lesions, CTOs, all below the exploratory primary endpoint of a 30% residual stenosis, which is very pleasing. And if we have a look at the Disrupt 1 and 2 highly selected cases in a randomized controlled trial and compared to the observational registry, we can see we still get the same, even better acute luminal gain and an excellent safety profile. Now, one of the things we've learned is in the real world, in fact, intravascular lithotripsy is often an adjunctive procedure, and adjunctive procedures will vary, including drug-coated balloons and stents. You'll notice in the iliacs, stents are very common after intravascular lithotripsy for very calcified iliac artery lesions, but in the common femoral and popliteal arteries, as well as the superficial femoral artery, it's usually a drug-coated balloon. Here's a case last week of a very calcified femoral bifurcation lesion that I managed here with intravascular lithotripsy followed by drug-coated balloon angioplasty with a pleasing result. So we've seen from Disrupt 1 and 2 that the shockwave therapy is safe and effective. However, restenosis is an issue at 12 months and is being addressed in Disrupt randomised controlled trial. We've seen excellent results in the observational registry treating more complex lesions. Most of these have an adjunctive therapy. Thanks very much.